this is actually very interesting.
It is always a dialogue. It is always a part of the conversation to understand how the tool works.
Your achievement would really be a big step. So let's just jump in. Hey, Sujoy, maybe first you can introduce yourself to us.
Thank you, ma'am. I am Dr. Sujoy Kar. I'm the Chief Medical Information Officer and Vice President here at Apollo Hospitals Group, India.
So we started our collaboration, J-Clinic collaboration with Apollo Hospitals quite a number of years ago. And it was an interesting journey, but today we will talk about the success of this group of bringing Mirai, which is our breast cancer assessment tool, to the clinic. So maybe we will first start with this achievement and you can tell us where we are with Mirai clinical implementation.
We started exactly on 20th January 2020, before COVID. So it's been a journey of 6 years working together with your team, ma'am, at MIT J Clinic and at CSAIL. So predominantly the first task for us was to look at the different mammograms that we had in our repositories at Apollo Hospitals, particularly looking at their longitudinal data and their progression to diseases. And that took us a bit of a time because we had to retrieve those images. We had particular challenges during the COVID time to retrieve data. But thereafter, we have been able to do appropriately the retrospective validation.
So the first step was to do retrospective evaluation. And what you said took some time is to put this data with an outcome, to compile it, because I guess in 2020 it was still early days of clinical AI and data still required curation before one can validate tool like Mirai. So do you remember how many images were used in validation?
Yeah, we took a cohort of around 35,000 individuals, out of which we had a particular challenge of retrieving the right kind of images for this particular algorithm to run through. At the end, we had about close to 3,500 individuals with longitudinal records who have more than 2 or 3 images over a period of 5 years. That's the cohort we selected, with about close to 8% of the population having known, breast cancer over a period of time. We went on to do the retrospective analysis of the Mirai algorithm on these mammogram and got fairly good results. In fact, better results than the other cohorts of this study.
Yeah, so this is quite amazing because Mirai was actually not trained on Indian population, even though I presume that Massachusetts General Hospital, where it was trained, did have, some women of Indian descent, but clearly this was not the majority. So this was very pleasing to see that, Mirai worked well in this population. And afterwards, so you saw that the model is validated. What was your next step?
Quite a few next steps, and most of these were to actually take the entire Mirai process to number one for prospective validation and getting the right threshold to determine and put Mirai into clinical practice prospectively. We had to do a few things. Go to the ethics committee, take their approval for multiple sites within Apollo Hospital, with a protocol that was co-built with MIT J Clinic researchers and scientists under your guidance, ma'am, but also the radiologists and people who work on breast radiology from Harvard Medical School, and also at least 3 top breast radiologists from Apollo Hospitals. So all of them came together to build a protocol, take it to the ethics committee, got the ethics committee approval in India. Number 2, we went for our ISO 13485 software as a medical device certification, including medical device single audit program, which ticks the boxes for process certification in Australia, Japan, Brazil, Canada, and of course, US FDA, apart from doing it for the fact with India. So those were the two important administrative parts that, and the certification, and also the protocol going through the ethics committee part.
So let me actually walk through these pieces, because I think there are many hospitals that now are undergoing this process, and even though you summarize it so succinctly, this is very, very challenging, because
Yes.
most of these committees, well, they are very qualified to handle other type of maybe medical devices and treatments. AI, at least at a time when you went for it, was still a novel technology, so there were many questions. Can you just show some example of challenges that you had to think about when you brought it to the committee? Like, was it the process that you just put something together and brought them, or it was more of a dialogue?
It is always a dialogue. It is always a part of the conversation to understand how the tool works, because in many ways, to judge on the ethics and safety of the tool, the evaluation at the ethics committee would go through those particular elements around the ethics, safety, and all. So the first thing was to actually tell them about how this was built, how this was retrospectively validated. What are the thresholds that we are going to use for people who are going to use it prospectively? Patients below the age of 40 with family history and others, patients above 40 who routinely come to us for screening. And then, of course, people who would be doing this at least annually. Plus, it is also important to determine how the different cohorts are looked at. One is, of course, having an element of retrospective prospective analysis, where we already have certain mammograms of individuals. How are we going to look at them from a prospective perspective? Then, of course, people who are starting completely new within our system. Then people who are only going to do once. How do we actually go about in interpreting Mirai, or for other tests like Tyracusic and others in their system as well? So all of these has to be put into protocol, their safety and ethics analyzed, consent forms developed, and then developed not only in English, but in different languages, Indian languages, and then go about in actually telling them how we would do it prospectively.
This is actually very interesting, because I noticed that the first question we get in the practical applications when we bring the tool to the hospital is, what are the thresholds? This is a real question. It's quite surprising that, in medical journals, this issue is rarely discussed, because if you look at NCCN guidelines and other, some of these thresholds were, established based on the literature from like 30 years ago, and we didn't revisit them. But clearly, we cannot just blindly take these thresholds and bring them to AI tools, because it very much determines, it comes together with deciding what do you do. If a patient is high risk, are you going to send them to MRI? Are you going to just making their screening more frequent, and all these questions? So maybe you can walk us through what kind of clinical pipeline you devise, in conversations with the specialists, both from local specialists in India, but also with clinicians from MGH, like Dr. Leslie Lamb. How did you come up with this pipeline that will fit your, local clinical needs?
That's a great question, and that actually ties up with the whole prospect in clinical AI to look at the outcome of an algorithm with how do we tie that up with a clinical pathway, and how relevant it is. And therefore, the threshold here becomes more important than how we have conventionally used thresholds in clinical medicine, where quite a bit of it is also about the physician's acumen themselves as to how they would go into looking at the cases, particularly at their own centers. But in this case, what we did was to put the clinical pathway for people with lower risk, people with intermediate risk, and people with high risk, particularly looking at, how do we go about in following them up? What is the frequency of follow-up? That we wrote it in our protocol very clearly. What are the modalities of follow-up, including further diagnostic imaging or tests that they would have to do? One, at the point of care, when we get to know about very high risk patients, or how we will follow them up over 6 months or 1 year period of time. So that's very important to actually put them into a sequential path. And then, of course, look at other ancillary tests, secondary consults, and then, go about in looking at education, which is a very, very important part into all of these, because, many of these women come from semi-urban or rural background with not so much health literacy, aspects that they know about. So one of the things that we put it into our clinical pathway very, very succinctly, and therefore, is something that we practice, is also to make women self-aware of their current risk profile and what they would need to do over a period of time. So to summarize, it actually, every clinical pathway then talks about in their risk categorization, immediate actions, consults, diagnostic imaging, other labs imaging that comes in, or other procedures that might happen. Of course, the frequency of their revisit, and of course, patient and family education.
This is amazing. So maybe you can tell us, what do you do about the patient which were in the highest risk category? And actually, I don't know if you've seen it, there was a recent paper in Lancet Digital Health that doesn't use Mirai but use other tools that looks at the imaging. And what they found out, that the patients for which these tools say that they are highest category of risk, their risk is actually the same as BRCA patients, which is a very, very high risk. And unfortunately, in today's system, if they don't have genetic mutation, these patients are not treated at all any different than an average risk woman, because neither the patient nor the provider knows that they're at risk. So what options do you have today for these patients which Mirai identifies very high risk?
We actually look at the breast imaging from a screening clinic perspective, with the first one done within the first 6 months of identifying that there could be a potential breast lesion, or Mirai predicts that the risk of having a breast cancer in the next 1 year is very high. So they will go and do an annual MRI starting age, as low as 25 to 30, if they have a history, or if they have a family history of that. Or they will then look at screening until the age of 40, and continue to do an annual breast MRI, as per the protocol that we are looking at. And then, of course,
But what happens to women who are, let's say, 43? This is the age that I was diagnosed. What happens to somebody who came to her annual mammogram at age 43 and Mirai identified her as high risk? Would you propose to this patient an MRI?
If the mammogram lesion already shows certain changes which are congruent to a pathology, obviously it goes to the directly referred to the breast clinic or breast surgery, where there is a clinical breast examination, and then it goes into the path of how we are looking at it from disease management progression. But if we do not have an active disease at this point of time and mammogram says high risk, that's where we will do MRI at that point. We'll possibly look at an MRI, a repeat MRI at 6 months or 1 year, depending when the patient comes back.
This is very interesting. So again, the very high risk patients, you are sending them to MRI. And I don't know if we discussed it earlier, but there is actually an ongoing trial in UMass Worcester run by Dr. Gopal, and they already show some very promising signs by sending high-risk women on MRI, which really was very high detection rate. So it's very interesting to see the same scenario applied to women, in India, and hopefully because Apollo hospitals are so big. How many patients does Apollo Hospital serve? Female patients, would you say? Is it in thousands?
On a daily basis?
Overall, let's say, what is your general female population?
Okay, so we would look at annually, we would see in outpatient clinic about 5 million patients
Wow,
on
wow.
an
So
on an outpatient. Yes,
it's really
5
a very large clinic, so it's not the size of
Yeah, yeah.
MGH
So
for sure.
5 million all over patients,
Yeah.
out of which I would say by rule of thumb, it would be around close to around 2 to 2.2 million women who are coming in. But associated with that, we also do close to about 3 million health checks, where screening mammograms are routine that we have been doing as a part. So we see that many number of patients who are coming with other conditions or events in the hospital, but we also see otherwise normal ladies who would not
Just do
have
yeah.
just come for their annual health checkup, and that number, if we look at, is close to about 1 to 1.3 million per year of women who are undergoing breast mammograms as a part of their annual health check.
This is amazing. So we discussed that what we are going to be doing, what you guys are doing. So the patients which are high risk, they either, if you see something, they're sent to further examination with a surgeon. If you don't see anything, they just have an option to come and do more
Yes.
frequent MRI. What happens with a cohort of medium risk patients?
Yeah, so that is a very interesting area that we have been looking at, and there has been a lot of things that have come in. They have looked at recommending anywhere between biannual to annual screening method. Some of these patients who have for 2 years, 3 years higher threshold, we would ask them to do at least one MRI annually to see how they are being looked at. This is what is there in the protocol. But we will continue to also collect data around certain other things, including looking at their breast, patterns in their mammogram or even in the MR. I know that there is another study that we are doing in terms of density of breast. We're trying to see how that density of breast, advocates supplemental screening, when the breast MRI is recommended. And then, of course, we are also looking at women with atypia or LCIS, whether they should have supplemental surveillance with MRI. So that is also being taken care of. And particularly women with elevated risk due to breast density, we are looking at if there are requirement to do adjunctive tests at this point of time. So they would also go through little sparse, but a method to actually get appropriate evaluation done at least once annually to see where they're heading to for moderate or intermediate risk.
And because again, you have such a big population, one thing that we can do, is over time when you collect more data, is actually to adjust the threshold. Because of course, on one hand, we don't want to delay the diagnosis. On the other hand, we don't want to overscreen. So because of this method, they can be easily adjusted on the population. We can over time to ensure that we, set the right balance between prevention and not over screening. So this is very interesting. And what happens to the low risk cohort?
Well, so we ask them to at least do their breast examination. We teach them about the clinical examination of breast as a part of, their routine follow-up. And at least once in 2 years, they would return to do a baseline mammogram using Mirai, which is again very indicative of where they are moving in that way. So if I may just add one sentence to what you just said, ma'am, is there's that the potential of Mirai is therefore as a screening tool to identify who goes on to follow after we know the thresholds very well, who goes on to follow the high risk or very high risk category and the moderate risk category. And then, of course, who are going to be at the low risk category. And with the results that we have got already on the retrospective cohort, and what we are anticipating as a part of prospective cohort, I think we are well placed in a way, maybe in another 2 to 3 years down the line, making Mirai and breast mammogram a way by which it is as good as any other screening tool available in the world at the moment.
Yeah, I'm really looking forward to it. And you touch based upon the density, and as we've did a lot of studies, density it's a very, very weak predictor of future cancer. It is indeed a predictor, not predictor, but a factor that may impact the fact that radiologists may miss cancer because it makes it harder. But as a risk factor, it's very, very weak. But I think that, what I loved about the approach that you've taken, you actually have many different tools in your toolkit. Some of them may be weaker, some of them are stronger. But to really make a convincing argument, one need to look at all this toolkit in a very large population and say, yeah, as you said, this is a clear winner, and in the future we're going to commit to this clear winner and even improve it. Those things seem not to be really helping us, and it's time to retire them. But of course, we can make this decision only based on the empirical evidence, and given the size of the Apollo hospital screening population, the statistics would really be very clear for us to say what's going on. So this is really exciting. And I want to share with you that I always get emails from, women who got diagnosed. And just yesterday, I happened to get an email from somebody who is diagnosed with stage 4 breast cancer. And, and the question that this woman asked me, and this is the same question that I had when I was diagnosed, how come, I did all these mammograms and I am healthy, how it happened to me? In her case, she immediately was diagnosed with stage 4, which most likely indicates that, the high risk profile, her early diagnosis were wrong. And I think that this particular example and many, many others really makes, the commitment of the institutions to bring change. And I'm so delighted that you are really leading in this effort and developing novel clinical practices that bring AI, clinical AI to help breast cancer patients. For that, I'm really grateful.
Yes, ma'am. The other very important aspect to this is that irrespective of how good the tool is and, the volume of patients we have, one of the important ways to actually get it through is also to integrate it into the workflow. And that is something that we have been able to do by able to integrate the Mirai as a tool into our radiology and PACS system, so that any radiologist wanting to use it or the screening that are happening through our health check automatically goes through that, and therefore we are able to get the results prospectively as we move on in doing this. So in fact, 3 things that we accomplished over a year was to get the protocol right, get the ethics committee right, get the ISO 13485 software as a medical device, an MDSCP certificate for Mirai. And third is to actually then go about in integrating into our PAC systems for prospective use.
This is really an amazing, amazing contribution. And people think it's hard to develop AI. I think the hard part is to bring AI to patients. And this is really a true achievement. And I'm sure that the results of this study and all this process would be very impactful for many hospitals around the world. including the United States, where Mirai is still not used as a standard of care, where we're still not bringing this great technology to benefit patients, your achievement would really be a big step, help to change the status quo. So I'm very, very grateful and can't wait to see, the results of your study. So thank you very much.
Thank you, ma'am. And we are equally grateful for this novel work. And I know that there would be some other iterations of these particular tool coming over a period of time. So looking forward to this in our journey of screening women as early as possible and putting them into a pathway. The other great news is that there are many other institutions world over who are looking at as to how we have implemented this, and they want to implement that in their regional hospitals or healthcare systems and see how that could benefit people across the world.
Thank you very much. And the Jameel Clinic is your collaborator and supporter, so we are there to help in this journey. So thank you very much.